I hope you guys are able to see me and hear me properly now. If the streaming is okay, please leave a thumbs up in the chat box. We can start with our class. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and this is the Anesthesia Revision Part 2 that we will be doing today. Oh yes, I can see that the streaming is absolutely fine. So let's begin with our class for today. We have already finished the part 1 of the revision. So in part 1 of the revision, we basically discussed about all the different types of anesthetic agents that we had, different instruments for regional anesthesia, and different types of LMA, supraglottic airway devices. In part 2, we are mainly going to be discussing all the capnographs which come as an important question in anesthesia, and we are also going to be doing a few other important case scenarios in anesthesia. Alright, so I hope that the streaming is fine. Can you guys just leave a thumbs up once to tell me that the streaming is okay? Yes. Alright. So my name is Dr. Jhanvi Bajaj. I am MBBS MD DNB in anesthesiology. I'm a gold medalist in anesthesia, and this is the Telegram channel Let's Crack NEET PG, on which we have the links to all of our classes. So I highly urge all of you all to join the Telegram channel so that you guys can get updated about the links about the classes. Now we have the All India mock test on 26th of February at 9 AM. And along with this, we will also give you detailed review and analysis of your performance in the test. Then the Plus subscription on Unacademy will help you get access to live and recorded classes. You can learn from India's top educators, and you can compete in live tests and quizzes. You can study on the device of your choice. We also have the Iconic subscription, which will help you get the Prep Ladder benefits like video lectures of Prep Ladder along with the Unacademy Plus subscription. These are our FMG toppers, and we also have the educator curated test series in medicine, in which you can attempt each of the individual tests in the subjects like medicine, orthopedics, gynec, surgery, and you can know your ranking in the same. In our special classes, they are available free of cost, and we have polls for the learners, we have raise a hand option, we have lecture notes at the end of the class, and they are available anytime and anywhere. These are all the batches that are going on right now. So we have the all educator revision batch, the target next 2023 subject wise batch, the focus FMG comprehensive batch for December and for this year. And if you would like to join the Unacademy Plus subscription, you can just use my code Dr. Jhanvi Live, with which you will get 10% off on your subscription. Alright, so with that, let's begin our class for today. We already finished these parts of the class. So this was about regional anesthesia, spinal epidural caudal, peripheral nerve locator, ultrasound, all the IV anesthetic agents. Then we had all the inhalational anesthetic agents, neuromuscular blocking agents, local anesthetics, cylinders, and supraglottic airway devices. Now we move on to the next part about the instruments. So can you guys identify these instruments for me? And can you tell me individually what are the names and uses of these instruments? What are the specific uses of it? So I'm marking it as 1, 2, 3, 4, and you can tell me the specific usages of these instruments. First of all, overall, what class of instruments do they belong to? Answer till then. I will just adjust the screen. I think there is some problem with the screen setup. Alright, so Narmata is saying all of them are laryngoscopes. Absolutely correct. And Kirtika is saying that blade number 2 is Miller's blade. Very good. So the straight blade that we have is called as the Miller's blade, and the curved blade that we have in number 3 is called as Macintosh blade. Absolutely correct. So if you see the Miller's blade is a straight blade, and it is used for intubation in pediatric patients. And then we have the Macintosh blade, which is a curved blade and it is used for intubation in adult patients. Then what is blade number 1 and what is blade number 4? Yes, very good. So blade number 4 that we have is a video laryngoscope. As all of you all can see, you can see the picture of the entire glottic opening while you're intubating the patient. You can see the epiglottis, you can see the vocal cords, and you can intubate the patient. So whenever you have a camera along with the laryngoscope, that becomes a video laryngoscope. And what is blade number 1? Anyone? Any idea? What is this blade and what is it used for? It looks a lot like the Macintosh blade, but it is not the same. Okay, so this is called as the McCoy blade. Just remember, this is called as the McCoy blade. Okay, so the McCoy blade basically has this lever that is present behind. And what does this McCoy blade do? Whenever you have a difficult airway, it looks very similar to Macintosh. It has a curved blade only, but when you press this lever down, this part will get lifted up. It is a flexible scope. This part gets lifted up and it lifts up the epiglottis. So you are able to see the vocal cords very well. Okay, so this is your McCoy blade. So you should know all these different types of laryngoscope blades. You have McCoy, you have Miller, you have Macintosh, and you have video laryngoscope. Now if they ask you in your exam which is the most commonly used blade in adults, which is the most commonly used blade in children. Okay, so in adults most commonly used blade is Macintosh, and in children most commonly used blade is Miller's blade. And the last, they will ask you in case of a difficult airway, which is the blade that you will use. In difficult airway you can use either McCoy or you can use a video laryngoscope. Alright, okay, moving on to our next picture. So you need to identify each and every part of this picture. So tell me what are they and what are these different types of tubes that you can see basically. And what are they individually used for? So you can see tube number 1, 2, 3, 4, 5. What are they individually used for? Alright, very good. So the first and the second tube that you can see, they are in conjunction called as the RAE tubes. RAE tubes, okay. What is the full form of RAE? It is named after 3 scientists, Ring, Adair and Elvin. And what are these tubes called as? Now the one which has a sort of right angle to it is called as the North Pole tube. And the one in which both the ends are facing in one direction only. So this end is facing in one direction, this end is facing in one direction. This is called as the South Pole tube. Alright, so you have the North Pole tube and the South Pole tube. Now what are these North and South Pole tube used for separately? So if you see, the North Pole tube is basically put through the nose, and this end of it now, this entire end that I am marking will go into the trachea normally, but this end that you can see of the tube, it goes up like this towards the north, towards up. Okay, so whenever I want to operate on the maxilla, on the mandible, on the thyroid, and I want the tube to stay out of the way of the patient, out of the way of the surgical field, I will use the North Pole tube. Similarly, the South Pole tube, this part that is there, the one with the cuff, will go directly through the trachea. The remaining part, this part, will go down like this. Okay, so suppose I want to operate on the tonsils, or I have some surgery on the nasal area or on the maxillary area. I want to keep the tube out of the location or the surgical field. Okay, so I can use the South Pole tube in that way. So if the tube is facing up like this, it is called as North Pole tube. If the tube is facing down like this, it is called as the South Pole tube. Both of them, if they ask you in your exam, are used for head and neck surgeries, and they are used for neurosurgeries. Alright, Okay, now tube number 3, can anyone identify tube number 3 for me? What is so specific in that? Something specific that you can see in tube number 3? Yes, very good, Narmata Devi. So tube number 3 that you can see has no cuff in it. Okay, so this is an uncuffed tube. So this is a uncuffed tube. So in tube number 3 I have no cuff. Now in whom do I use an uncuffed tube? I use it in pediatric patients. Now why do I use an uncuffed tube in pediatric patients? Just look over here. In pediatric patients, this is how my larynx is. My vocal cords are here and I have a narrow larynx over here. So when I have a narrow larynx, what happens? My tube goes in like this. Okay. Now when I inflate the cuff over here, it can cause stenosis of this narrow part. So instead of having a cuff over here, I use an uncuffed tube so that there is no stenosis of the subglottic area. Okay. So uncuffed tube is used in pediatric patients. It helps in preventing subglottic stenosis. Helps in preventing subglottic stenosis. Alright. Okay. Now can you identify tube number 4 for me? Anyone, can you tell me what is the problem with an uncuffed tube? If I have an uncuffed tube, it can lead to aspiration of gastric contents. So aspiration chances are high with an uncuffed tube, but subglottic stenosis chances are low with an uncuffed tube. Anyone, tube number 4, what is the tube number 4? Tube number 4, anyone can identify for me? What type of tube is it? Yes, absolutely correct. So if you look at tube number 4, okay, so tube number 4 is a normal cuffed endotracheal tube. There is no difference in it. It's a normal cuffed endotracheal tube. And then tube number 5 that we have over here, any idea what it is? It is actually having rings inside it, which you are not able to see here. I'll show you in the next picture. Okay. Now try to identify these pictures for me. Alright, so can you guys identify these different types of tubes for me? Tube number 1, tube number 2, tube number 3. What are all these different types of tubes? Yeah, so your tube number 1 and tube number 2 that you see over here, they are similar tubes. Okay, so you can see inside it there are metallic rings. Alright, so these are the metallic rings that are present inside these tubes, and these metallic rings basically make it flexible. So they are called as flexometallic tubes. Flexometallic tubes. The other name of flexometallic tubes is nothing but armored tubes. Now they'll ask you in your exam, what is the use of flexometallic tube or armored tubes? So they are also used for neurosurgery and head and neck surgery. And why do we use this flexometallic and armored tube for neurosurgery or head and neck surgery? It's basically because you want to make sure that the patient's head, if you move it around like this, okay, suppose this side of the brain has to be operated on, or this side of the brain has to be operated, or if this side of the mouth has to be operated, when you're moving the head and neck area of the patient's airway, there is no kinking of the tube. Okay, so to prevent kinking of the tube, we use this flexometallic tubes. Okay, so can you see they are trying to tie a knot over here with the tube, and still the tube is not getting kinked in it. Okay, now can anyone identify tube number 3 for me? This is like super important tube. This comes many times in the exam. It has already been asked in all possible exams before. I'm so sorry guys, I'm just trying to get this background light off the grey shadow that is coming, so that's why I'm getting up again and again to switch on and off the light. All right. Yes, absolutely correct. So tube number 3 that you can see over here is nothing but a double lumen tube. It's a double lumen tube. It is used for one lung ventilation. So when do you need one lung ventilation? Remember, whenever we have thoracic surgery, when we are operating on the lungs, okay, so suppose there's a tumor on one side of the lung and the other side of the lung is normal. So when you have to ventilate the patient on one side, now I want to ventilate only this lung, the other lung has to be deflated, the one which has tumor, because I want to operate on it. So for one lung ventilation, I will use this double lumen tube. Alright, clear guys? So these are the different types of endotracheal tubes that we have that can be asked in your exam and that you should be aware about. Okay, moving on to our next picture. So can you guys identify what are all these different things and what are they used for? Very good, Raja Deepan. So these are nothing but airways. Okay, so here we have the airways that are present. So can you tell me what is airway 1, what is airway 2, what is 3 and what is 4? They are called as airway adjuncts. Airway adjuncts. Not protector, they are called as airway adjuncts. Okay. So they help in securing the airway. Can you tell me what is 1, 2, 3 and 4? Yes, very good. So one is nothing but oropharyngeal airway, or it is also called as Giddle's airway. One is oropharyngeal or Giddle's airway. 2 is called as nasopharyngeal airway. Also you can see how these airways are inserted in the patient. Okay, so the Giddle's airway, you can see it's inserted in the oral cavity and it is pushing the tongue behind. Then the nasopharyngeal airway is put through the nose and it is pushing the tongue in the front. Look here, it is pushing the tongue in the front. Then what is 3 and what is 4? Anyone? Can't see the 4th. Okay, I'll just move a little bit so that you guys can see. I'll stand up so that you guys can see the 4th picture. So can you guys see the 4th picture now? Was able to see? Okay. So the 4th picture that you can see over here is nothing but the steelet. Steelet. And the 3rd picture that you can see over here is nothing but the bougie. You have the bougie and you have the steelet. Okay. Now what are the bougie and the steelet used for? So first we'll discuss about the bougie. So imagine your airway, your vocal cord opening that you can see is, instead of being this entire vocal cord opening, the only thing you can see is this. This is your epiglottis. So imagine you can just see this much part. That's it. So in this case, what will you do? So in this case, when you can't see the entire airway opening, what you do is you pass this thin bougie first. Okay, once the thin bougie goes, then on top of that you can pass the normal endotracheal tube. Okay, now the next, why do you use a stillet? So stillet is when you have an anterior larynx. So suppose you have Shah Rukh Khan coming in for surgery and you want to give him anesthesia. Now you know that his throat or his larynx is very anterior. It's seen very obviously, correct? We call it as the Adam's apple, or we call it as the lucky charm. So in that case, what you do is to intubate an anterior larynx, I use a stillet. So I put this steel stillet inside a endotracheal tube. Imagine this blue thing that I'm drawing is endotracheal tube, and then I turn this endotracheal tube, or I curve this endotracheal tube along with the stillet. Okay, so it helps me in curving the endotracheal tube, giving it an anterior tilt so that I can intubate the patient easily. Alright, is that clear? Okay, now look at all these things over here and identify what are we talking about in this case. What are the things that we are talking about in this case? Yes, very good. So these are called as the oxygen delivery systems. Absolutely right. So these are my oxygen delivery devices. So can you guys identify each of these oxygen delivery devices for me? I'm going to mark it as 1, 2, 3, 4, 5 and 6. Whichever ones you know, write the number and write the name of the oxygen delivery device, and also write how much FiO2 does it deliver. Batao, any of these oxygen delivery devices that you guys can identify, and how much FiO2 does it deliver? Narmata 4 is low flow system. No, there is no low flow system as such. 2 is nasal cannula, absolutely correct. More than nasal cannula, the correct name for it is nasal prongs. You all must have seen this. We usually put it in patients who come to the casualty. How much is the FiO2 given through the nasal prongs? How much is the FiO2 given through it? Four is oxygen mask with reservoir. Yes, but what is the name of that mask then? If I'm using an oxygen mask with reservoir. No, you cannot use up to 6 liters. Okay, so in nasal prongs, the FiO2 given is 40%. Maximum FiO2 given is 40%. Okay. This is the reservoir bag, absolutely correct. And this is the oxygen mask, you're right. But what is the name of this entire apparatus called as? I am asking you FiO2. I am not asking you how much liters of oxygen can you give. FiO2 means how much percentage of oxygen will you give. Come on, Raja Deepan, Swiss Cheese, Kirtika, Akshay. What are your answers? Yes, very good, Raja Deepan. So this is called as non-rebreathing mask. This is called as NRBM or non-rebreathing mask. And how much is the FiO2 you give through non-rebreathing mask? Very good, Akash. So this was the question that was asked in NEET last year, and the FiO2 given through the non-rebreathing mask is nothing but 80%. Okay, 80%. Sorry, this was asked in INI-CET, not NEET. Alright. What about picture number 1? Anyone? Can you guys identify picture 1 or can you guys identify picture 5, 3? Second to you should be able to identify this picture number 3. This is a normal Hudson mask. Correct? This is the one that we use whenever patient comes to casualty. The maximum FiO2 that you give with the Hudson mask is 60%. Have a look at this mask. This is the normal Hudson mask and this is the nebulizing chamber. So if you want to nebulize with salbutamol or Budecort or plain normal saline, you can fill it in this nebulizing chamber. Yes, very good Raja, very good Akash. So the first picture that we see over here is nothing but HFNC, high flow nasal cannula. How much is the FiO2 given with high flow nasal cannula? And what are the parts of the high flow nasal cannula? You can see it has a humidifier. It has all these tubes that are coming from here. It is filling it with oxygen, humidifying the oxygen, warming the oxygen, and then giving it to the patient through the nose. Okay. So high flow nasal cannula gives FiO2 of 100%. Okay. What about 5? Yes, very good Akash. So 5 is nothing but non-invasive ventilation. Non-invasive ventilation, it is connected to a ventilator. You have big tubings that are there that are going to the patient's face, and then you have a mask that is tightly attached to the patient's face, very tightly attached, so that there is no leakage of oxygen. Okay, so this is called as NIV. Alright, what about 6? Any idea? In 6? That 6 is not clear. Okay, you're not able to see it. I'll just move a little bit, then you guys can see it. Can you see it now? Or have I moved in the wrong direction? Yeah. Is 6 visible well? BiPAP, no. Look at how it looks like. Does it look like anything specific? I think it looks like a helmet. Correct? Yeah. So 6 is actually called as a oxygen helmet. 6 is called as a oxygen helmet or a oxygen hood. Okay. So oxygen helmet or oxygen hood that is there, it will help to provide a FiO2 of about 90%. Now it is used in pediatric patients. In pediatric patients, they don't like to put a tight mask. They don't like to put anything in their nose. So instead of having nasal cannula or having an NIV mask, we can put a oxygen hood on them. Okay. So these are all our different types of oxygen delivery devices. For those who have come in late, I'll show you all that has been done till now. We've done the different types of airways, oropharyngeal airways, nasopharyngeal airways, bougie, stellate. We've done the different types of oxygen delivery devices like HFNC, nasal prongs, Hudson mask, NRBM, NIV and oxygen hood. Alright. Okay. Now we are moving on to the different types of positions in anesthesia. So can you tell me what are these individual positions and what are the problems with these individual positions? What are these individual positions and what are the problems with these individual positions? Akash, how to remember FiO2? Okay, so you can make a list of lowest FiO2 to highest FiO2 and you can remember it accordingly. Okay, very good. So you can tell me what is the position. A is this, B is this, C is this. So A is supine position, very good. B is, head is down, so it is Trendelenburg position. So tell me in Trendelenburg position, what is the problem that I can get? I will have an increase in what? In Trendelenburg position, what is the problem that I can get? I can have an increase in the intracranial pressure and the intraocular pressure. All the blood is going towards the head. So I can have raised ICP. So in a patient who has a neurological problem already has high ICP, I should avoid Trendelenburg position. Okay, or a patient with glaucoma, I should avoid Trendelenburg position. In fact, in them I should give ulta position, or that is called as reverse Trendelenburg. Okay. Now, what is the problem with reverse Trendelenburg position? All the blood will go down to the lower limb, so the venous return will be less. So, as a result of this, in reverse Trendelenburg position, my venous return will be low, so I will have less BP. I will have low preload and less BP. Okay. Alright, what is option D? Option D, you all must have seen in Gynac. Yes, Staphylococcus, very good. So, it is nothing but lithotomy position. What is the most commonly injured nerve in lithotomy position? Most commonly injured nerve in lithotomy position. Alright, E. Staphylococcus has written that it is lateral. Can you tell me whether it is right lateral or left lateral? Yeah, in lithotomy position, remember you strap the legs like this over here, correct? So, the lateral part of it, that is the common peroneal nerve, can get injured. So, you have common peroneal nerve palsy. Okay, common peroneal nerve palsy. Alright, in E, what is the nerve that is injured? Sorry, what is the position that we have in E? So, remember whichever side is down, it is that side lateral. So, here the right side is down, so we have right lateral position. So, the right side eye, the right side ear, the right side knee can all get injured. So, you should make sure they are well padded. Now, when in the lateral position you give a angulated bend like this to make this area obvious, this is called as the kidney position. So, your kidney, your left side kidney is a little elevated, so you can carry out your left kidney surgeries in this position. Okay. Now, what is position H? H. H, patient is completely on his front part. This is called as prone position. What is the most dreadful injury that I can see in prone position? Azad, E and F, that is the difference. In E, you don't have the table broken like this. In F, see, the table is broken at this level. Can you see? There is a bend between the two parts of the table, so that this part becomes more obvious, kidney part. Yeah. So, in prone position, what am I most worried about? Liver. No. In prone position, I am most worried about my eye injury. Okay. Because the face is down like this, so the pressure is coming on the eyes. So, I am very concerned about eye injury. The second thing that can happen in prone position is that my tube is going like this down. So, the tube can also get dislocated, or it can get removed, and I won't even realize because I can't see this part. So, what people usually do is, if I am using all these positions during surgery, especially prone position, then I keep a mirror over here. Okay, so I can, if the tube is coming out, I can see it in the mirror. Okay. Alright, and the last position that I see over here, I, is called as beach chair position, or it is called as Fowler's position, or it is called as semi-sitting position. Beach chair, Fowler's, or semi-sitting position. Alright. Okay, so in this beach chairs, Fowler's, or semi-sitting position, what is the problem that I see? So in this, you will see the patient is sitting like this, correct? So what will happen? Again, the blood is all going down, so the venous return will be less, so my BP will be low. My BP will fall in this patient. And what is another problem that I have? I can get venous air embolism in the sitting position. Okay, so that is most commonly seen in sitting position. For those who can't see the sitting position, I am just showing it over here. Sure, Shamsha, you can see all the different types of positions. A is supine, B is Trendelenburg, which leads to raised ICP and raised IOP. Then C is reverse Trendelenburg, which leads to fall in the BP. D is lithotomy, in which I can get common peroneal nerve palsy. E is lateral position. F is kidney position. H is prone position, in which I can get eye injury. And I is beach chair, Fowler's, or semi-sitting position, in which I can get venous air embolism and hypotension. Alright. Okay. Alright. Now, question for you guys. So, from here we are going to start diagnosing some capnographs. So, the EtCO2 value on the monitor is measured at the end of which phase? So, you all know that when we draw a capnograph, there is different phases. So EtCO2 value is seen at the end of which phase? 1, 2, 3 or 4? So you should know the phases of the capnograph. Okay, Mula is saying C, Akash is saying C, Staphylococcus is saying D. Okay guys, so if you see over here, we have the basic phase 1 in which your EtCO2 value is 0. Then this is the phase of expiration or expiratory upstroke, phase 2. Then we have the plateau phase, which is the phase 3, and then we have the phase of beginning of next inspiration, that is phase 4. So the EtCO2 value is measured at the end of phase 3. That is the value that you get. Can anyone give me the normal EtCO2 value? What is the range of the normal end tidal carbon dioxide value? Give me the range of EtCO2. Yes, 5 to 15 mm Hg? No. The normal EtCO2 is 35 to 45 centimeter of water. 35 to 45 centimeter of water. Okay. Alright. Now we are going to diagnose some capnographs and what has happened to the patient. So this is the capnograph of a patient. So this is your EtCO2 value and this is versus time. This is the capnograph of a patient who has been intubated and he has been placed in the prone position. Can you identify the problem that has happened over here? This is when you intubated him and this is after placing him in prone position. What has happened over here? So this is the prone position as I had shown you all. Patient is completely with his face in the front. Yes, very good Akash. So this is nothing but accidental extubation. Okay. So while making the patient ulta, okay, like how you, while making egg omelette or while making an dosa, when you flip it over, okay, so what can happen? Things can fall apart, correct? So when you flip the patient over, you make him from supine to prone, the tube can come out. Okay, if you have not stuck the tube properly, if you have not inflated the cuff properly, the tube can come out. So as a result of this, what has happened? Accidental extubation has happened. So you can see a normal EtCO2 initially when you have intubated, and after making him prone, EtCO2 is decreasing and suddenly it is disappearing. So the patient has had an accidental extubation. Okay. Yeah, everything gets spilled out of the pan. Like that, the patient is getting extubated. So tell me, what will be your next step in this case? If the patient is getting extubated, what will you do? What will you do in this case? Suddenly you see there is no EtCO2. Is there anything you would specifically like to do? Okay, so I will turn the patient again. I will make him supine, I will make him straight and I will re-intubate the patient. Alright? Okay. A patient now, the next one over here. This is the EtCO2, this is the time. A patient undergoing abdominal surgery under halothane suddenly shows increase in his EtCO2 from 40 to 100 along with increase in his core body temperature to 40 degrees Celsius. What do you think is the diagnosis in this case? Rebreathing. No, that is not correct. Anything else? Increased breathing, no. Look at what has happened, guys. He's undergoing surgery under halo thing. There is sudden increase from 40 to 100 and there is increase in his core body temperature also. Yes, very good, Hannah. Very good, Akash. Finally, you all have got the correct answer. This is nothing but malignant hyperthermia. Okay, this is malignant hyperthermia. So what is happening over here? On exposure to halothane. So whenever you get exposed to any of the inhaled anesthetic agents, halothane, sevoflurane, desflurane, isoflurane, any of them, or exposure to succinylcholine or scoline, what can happen to patients who have the malignant hyperthermia gene? They can start getting hypercarbia, excessive EtCO2 production. They can start getting temperature increase in the body. So there is hyperthermia and there is breakdown of the muscle. So there is rhabdomyolysis. Okay. So this is a typical pattern of the EtCO2. This is also called as the step ladder pattern. So you can see doubling of the EtCO2. Correct. The EtCO2 was first 40. Now it has become 100. So there is doubling of the EtCO2 and step ladder increase in EtCO2. So this is seen in case of malignant hyperthermia. Okay, what is the treatment? Drug of choice, anyone? Treatment or drug of choice? Yes, drug of choice in this case will be dantrolene sodium. Very good. Alright. Okay. A first-year anesthesia resident intubates a man undergoing laparotomy after 2 unsuccessful attempts. On intubation, the capnograph looks like below. What does it signify? Okay, very good, Akash. So what can you see over here? Initially, as you intubate, you can see a normal EtCO2. It's coming almost up to 30. Okay. Then the next EtCO2 graph has fallen. The third EtCO2 graph is even less, and then you have 0. So this capnograph is seen immediately on intubation. So if immediately on intubation you are having a fall in EtCO2, that means you have intubated in the esophagus. Now, can you tell me, if I intubate the esophagus, why should I have any carbon dioxide coming out? From the esophagus, why should I have carbon dioxide coming out from the esophagus and from the stomach? Ideally, the carbon dioxide should be exhaled by the lungs, correct? So, why should I have carbon dioxide from the stomach or esophagus? Okay, remember, whenever you are intubating the patient, when you initially ventilate the patient, some amount of air goes into his esophagus and stomach. Now, if I put a tube in the esophagus, that air, that carbon dioxide which had gone in the beginning comes out. So, initially you get 1 EtCO2, then you get fall in that EtCO2 and then suddenly it will be 0. Okay. So, this is nothing but a esophageal intubation. What will be your next step? Remove this tube and re-intubate again properly into the trachea. Okay. This is the capnograph of a patient undergoing hysterectomy under general anesthesia. What is the next step? Yes, very good. So what is this thing called over here? This thing that is present over here? Any idea? Very good, GK. So this is called as Curar Cleft. This is called as Curar Cleft. Okay. So what is Curar Cleft? Curar Cleft is basically when the patient takes his own inspiratory attempt. So ideally when you see a normal EtCO2, it is proper like the square waveform, correct? When you start getting this cleft, that means the patient is trying to take his own breaths. trying to take his own inspiration. Okay, so this Curar Cleft that you see is because the patient is out of the action of muscle relaxant. So what do you do? What is the next step? Next step will be to give a top up of the muscle relaxant. So patient has spontaneously started breathing, so you have to give him muscle relaxant again. Alright. This is the capnograph of a patient who has just been given antibiotic test dose. What should the anesthetist expect? Very good, Akash. Excellent. So this is bronchospasm, but can you tell me why is the bronchospasm happening? Why are you having the bronchospasm? So this appearance of the EtCO2 that we get is called a shark fin appearances. It looks like the fins of a shark. Why do you get this? You have just given antibiotic test dose. Patient may be having allergy to the antibiotic. So this is a part of anaphylaxis. Okay. So why do you get this? Imagine this is your normal bronchus. Okay. And the carbon dioxide easily leaves through the normal bronchus. Now during an anaphylaxis, your bronchi get very narrowed. So when they get narrowed, it takes a long amount of time for the EtCO2 to come out. So it takes a long amount of time for the carbon dioxide to come out. So instead of coming out quickly like a straight waveform, you are having a delayed release of carbon dioxide. So that is why through the narrowed bronchi, so that is why you are having this shark fin appearance. Yes, what will be your treatment for this? You don't need to give adrenaline IM, you can give adrenaline IV to the patient. IV adrenaline to the patient. Okay. Alright. Next one. A patient is undergoing laparoscopic cholecystectomy under general anesthesia. The anesthetist accidentally trips while trying to attach a new IV fluid pint. The monitor starts alarming. What should she expect? So what is happening over here? Yes, very good. So this anesthetist that we have is very clumsy. So she is tripped while trying to attach the new IV fluid. So what has happened? Suddenly you see there is a fall in EtCO2. So this diagnosis of the capnograph is that of a sudden fall in EtCO2. Now you have to tell me 2-3 reasons for sudden fall in EtCO2. So suppose you have disconnection of your circuit. Okay, your airway circuit gets disconnected. Second, if you have accidental extubation, suppose the tube comes out by mistake. Endotracheal tube comes out by mistake. Okay. Third is if you have sudden cardiac arrest. Sometimes because of a vasovagal attack, you can have a sudden cardiac arrest. So again, you will have a sudden fall in EtCO2. So these are all your reasons of sudden fall in EtCO2. Okay. So in this case, accidentally he has tripped. Mostly he has fallen on the circuit and led to disconnection of the circuit. Alright. I'll just move so that you guys can see the reasons. Dikh raha hai na sab? If anyone cannot see, please tell me. I'll write on the other side. Alright. Next one. Okay. The anesthetist notices this capnograph when the surgeon is cutting through the right lobe of the liver during liver resection surgery. What should he be vigilant of? Hypotension, okay. Displacement of tube, again no. Displacement of tube will lead to sudden fall in EtCO2. So here what you are seeing is there is a gradual fall in EtCO2. Okay, so have a look over here. This is sudden fall in EtCO2 versus over here. Over here you are having a gradual fall in EtCO2. So what are your causes of gradual fall in EtCO2? First is if you have hypotension. So less amount of carbon dioxide will be carried to the lungs. So that is why you will have fall in EtCO2. Second is if you have blood loss. Again same thing, blood loss will lead to hypotension. Hypotension will lead to fall in EtCO2. And third, if you are having a pulmonary embolism. Again there will be hypotension, less amount of carbon dioxide carried to the lungs, and there will be gradual fall in EtCO2. Okay. Third, there is another fourth reason, and that is hyperventilation. If you hyperventilate the patient also, you will have gradual fall in EtCO2. So these are all the reasons for gradual fall in EtCO2. Out of these 4 reasons, what do you think has happened in this case during the liver resection surgery? What do you think is the cause of fall in EtCO2 in that case? Yes, very good. So mostly the cause of fall in EtCO2 is because of the cutting through the right lobe of the liver, which is leading to, no, it is mostly because of blood loss that you are getting this. Okay, when you cut through the liver, liver is a very vascular organ, so you can have gradual fall in EtCO2 because of the blood loss. Alright, yeah, blood loss leading to hypotension, leading to gradual fall in EtCO2. Okay, next one. OT technician has not checked the machine since the last 10 days. This is the capnograph in the last case of the day. What should the anesthetist look for? Yes, very good. So this is the typical pattern that you see on rebreathing. Rebreathing, okay. So you are rebreathing the carbon dioxide. Can you see if it is not touching the baseline? This is your baseline. This is the baseline, and your EtCO2, your capnograph is not touching the baseline. If it's not touching the baseline, that means you are rebreathing the carbon dioxide during inspiration. How are you rebreathing the carbon dioxide during inspiration? Because your carbon dioxide absorber is exhausted. So whatever is your carbon dioxide absorber, soda lime, bara lime, Amsorb, whatever it is exhausted. It needs to be changed, and that's why you are rebreathing carbon dioxide in the next inspiration. Alright, so just quickly showing you all. Okay, one more, last one. There are 2 more exactly. You are called to conduct a case in a hospital with a very old anesthesia machine. This is the capnograph seen on the machine. Which part of the machine is faulty? I'll give you 4 options for this. A, expiratory limb or valve. B, inspiratory limb or valve. C, carbon dioxide absorber. D, needs more information. Okay, what is your answer? A, B, C or D? What is the part of the machine that is faulty? Okay, very good. So you should know how to read the phases of the capnograph, correct? So here this is phase 1, this is the phase 2 is the phase of expiration, phase 3 is the phase of alveolar plateau, phase 4 is the phase of inspiration. So where is the problem occurring? You can see the phases, phase 4 or the inspiratory phase is affected. So definitely something is wrong with the inspiratory limb or inspiratory valve because the inspiratory phase is affected. Okay, so that is how you identify your problem with the capnography. All right. A child is undergoing diaphragmatic hernia repair. The anesthetist is confused by the capnograph. What does it show? Yes, very good, Narmata. Absolutely correctly identified. So this what you can see. This is called as cardiac oscillations. Okay, and this is very normal in children. Now what happens is these are your lungs and this is your heart in between. So the heart lung barrier that is there is very thin in children. So whenever the heart palpates, okay, or so whenever the heart beats, the palpitations or the contraction of the heart produces vibrations that are carried to the lung, and those vibrations can be seen on the EtCO2 or capnograph as cardiac oscillations. Okay, so these cardiac oscillations are absolutely normal occurring. Okay, then next one, double plateau line is seen with. This is the double plateau line. So you can see one plateau over here, second plateau over here, one plateau over here, second plateau over here. So double plateau sign is seen in which condition? Hypothyroidism, hyperthyroidism, inspiratory valve malfunction, or faulty EtCO2 sampling line. Yes, so the only option that we have left right now is faulty EtCO2 sampling line. So just remember this double plateau sign is seen with the faulty EtCO2 sampling line. Okay, alright. Okay, now quickly, since we'll just see all the capnographs we've seen till now, we'll quickly revise all of them. So this is the normal capnograph. This is capnograph of sudden fall in EtCO2 in case of accidental extubation. This is step ladder pattern seen in malignant hyperthermia. Then this is esophageal intubation graph, Curar Cleft seen when the patient is out of muscle relaxant, shark fin appearance seen in bronchospasm, sudden fall in EtCO2 seen if you have disconnection of circuit, accidental extubation or cardiac arrest, gradual fall in EtCO2 seen if you have hypotension, blood loss, pulmonary embolism or hyperventilation, rebreathing pattern when carbon dioxide absorber is exhausted, then inspiratory valve misfunction, cardiac oscillations and double plateau sign. Now let's move on to our pre-anesthesia orders regarding medications. So can you tell me antihypertensive agents should be continued or stopped on the day of surgery? If they ask you patient is to be operated today, should we stop or should we continue the antihypertensive agents? Are you sure? Okay, we should continue all except two of them. We should continue all except two of them. Which two? Yes, very good. So we should continue all except ACE inhibitors and angiotensin receptor blockers. Okay, they both, if continued on the day of surgery, can cause refractory hypotension. So those two cannot be used. Okay, what about anti-diabetic agents? Anti-diabetic agents, should we continue or stop on the day of surgery? So we have OHAs and we have insulin. Should I take them on the day of surgery or no? Yes, very good. So OHAs and insulin should be omitted on day of surgery. Why? Patient is fasting, already sugar levels will be low. If you further give him OHAs or insulin, there will be further hypoglycemia. So I will skip the OHAs and insulin on the day of surgery. Thyroid disorders. So if I have hypothyroidism, I will be on thyroxine supplements. If I have hyperthyroidism, I will be on antithyroid drugs, correct? Neomercazole, carbimazole, all of them. So which one should I continue? Which one should I stop? Yes, so all my thyroid supplements, all of them, whether I'm hypo or hyperthyroid, I should continue all of them on day of surgery. Okay, does not matter. I have to be in the euthyroid state during surgery, so I have to make sure I continue all of these agents perioperatively. Now, can you tell me if I skip the hypothyroid agents? So, if I skip the thyroxine for a few days, what can happen? If I skip the antithyroid agents for a few days, what can happen? What are the complications related to hypothyroidism and hyperthyroidism perioperatively? Yes, so Raja Deepan, you're right. Perioperatively, hyperthyroidism can lead to thyroid storm, and hypothyroidism can lead to what perioperatively? It can lead to myxedema coma. Okay, so that's why I have to make sure my patient is euthyroid. Okay, now specific anticoagulants and whether they should be stopped or continued. Aspirin, clopidogrel, low molecular weight heparin, unfractionated heparin. बताओ. Aspirin and clopidogrel continue. Patient will bleed to death. Yes, very good. So aspirin continue on day of surgery. Clopidogrel I have to stop. Very good, Narmata. Clopidogrel has to be stopped 7 days prior to surgery. What about low molecular weight heparin? Low molecular weight heparin continue? No, that's not correct. Yeah, low molecular weight heparin also stop 12 hours prior to surgery. Unfractionated heparin? Unfractionated heparin stop 4 hours prior to surgery. And warfarin? Warfarin stop 5 days prior to surgery. Okay. Alright. What about my antipsychotic medication? Should I continue or should I stop all of them? Antipsychotic medication, should I continue or stop all of them? Yes, very good. So all my antipsychotic medication should be continued on day of surgery. I don't want my patient going into any state of mania, depression or bipolar disorder or anxiety or panic attack on the day of surgery. Okay, so I'll continue all of them except one agent. Can you tell me which agent? No, MAO inhibitors can also be continued now. There's only one agent that I don't want to continue. Any idea? Except lithium. Okay, lithium has to be stopped 48 hours prior to surgery. Why lithium? Because lithium can lead to interference with the metabolism of the anesthetic agents. So I need to stop it prior to surgery. Okay, 48 hours prior to surgery. Okay, now quickly tell me the fasting guidelines. How many hours prior to surgery can I give clear liquids? How many hours prior to surgery can I give clear liquids to the patient? Very good, 2 hours. How many hours prior to surgery can I give cow's milk? No, Raja. Cow's milk is not 4 hours. I knew you all will make that mistake. Yeah, cow's milk is 6 hours. Okay, how many hours prior to surgery can I give tea and biscuit? Six hours, very good. So light meal like tea and biscuit can be given 6 hours prior. How many hours prior to surgery can I give vada pav? Vada pav? Vada pav? Vada pav is full fatty meal, so 8 hours. How many hours prior to surgery can I give breast milk? Breast milk can be given how many hours prior to surgery? 4 hours. Formula milk can be given how many hours prior to surgery? Formula milk, not 4 hours. Wrong. Yes, very good. Formula milk can be given 6 hours prior. Okay, so basically where they confuse you in the exam is in all these different types of milk. So breast milk, remember it is human milk, it is easily digested. So 4 hours is enough. But formula and cow's milk is not human milk, non-human milk. So it takes more time to digest. So it is 6 hours. Light meal, light non-fatty meal, again 6 hours. But if you have a full fatty meal, then it will take 8 hours. Okay. So that is it with our discussion, and I will quickly show you what all we revised today in anesthesia so that you all have an idea about it. So we discussed all the different types of regional anesthesia and their instruments. These are spinal, epidural set, caudal used for central neuraxial blockade. Then the instruments used for regional anesthesia like peripheral nerve locator and USG. Then different types of IV anesthetic agents and their indications, contraindications, side effects, everything like propofol, ketamine, etomidate and thiopentone. Inhalational agents, ISO, SIVO, DES, HALO, indications, contraindications, all of that. Neuromuscular blocking agents like scoline, VEC, ROC. Local anesthetics like lignocaine, bupivacaine and intralipid used in last. Then different colors of anesthesia cylinders, different colors of pipelines, pin indexes, and different types of supraglottic airway devices, classic, supreme, intubating LMA, fast track, ProSeal, Ambu LMA, iGel LMA, different types of laryngoscopes, your McCoy, Miller, Macintosh video laryngoscope, different types of tubes, RAE tubes, North Pole, South Pole, uncuffed tube, armor tube, double lumen tube, flexometallic tube, different types of airway adjuncts, oropharyngeal airway, nasopharyngeal airway, bougie, stillet, different types of oxygen delivery devices. So and they are FiO2, that is your HFNC, nasal prongs, Hudson mask, NRBM, NIV, oxygen hood, different types of positions and the complications that come with each of them: supine, Trendelenburg, reverse Trendelenburg, lithotomy, lateral, kidney position, prone position, and beach chair or Fowler's position. Then different types of capnographs. So we had seen all the different types of capnographs. It's not seen over here because I removed the annotations. And the pre-anesthesia orders regarding all the medications, the fasting guidelines. So the almost 80 to 90% of what is asked in your exam has been revised in these 2 sessions. So if you like the session, please don't forget to leave a thumbs up at the end of it. And also I will be taking plus course from tomorrow for the target next 2023 students. So in that I will be discussing anesthesia in detail. So if you would like to join the plus course, you can use my code Dr.Jhanvi live and you guys can use that code for your plus subscription. Yeah, can you give the list? I will write it down over here, FiO2. So one second. So we start off with the lowest FiO2 that is given by nasal prongs, 40%. Then we have oxygen mask or Hudson mask, which will give 60%. Then we have non-rebreathing mask, which gives 80%. Then we have NIV, HFNC or intubation, which gives 100%. In beach may sometimes they ask oxygen hood or oxygen tent, that gives about 90%. Okay, so these are all your different types of airway devices and the FiO2 that they deliver. Alright, so I hope this was useful for you guys and I shall see you for the plus course from tomorrow. Till then, take care and keep studying. Bye bye.